Well, this is a bittersweet time in the conference. We're about to start the very last session. For some of you, I know you're sad, you're going to be leaving Chicago. But it's been a great conference, I think, and looking forward to this last session. I'll introduce the moderator for this session is Dr. Micah Prohaska, who is an associate professor of medicine and also associate director of the MacLean Center and also co-director of the Ethics Consultation Service. And if you notice on any of the slides that have been scrolling about the concentration in biomedical ethics with the master's degree program, that would not have happened without the incredible work that Dr. Prohaska has done. So Micah, I'll introduce you to moderate the last session. Thank you.
Thank you, Peter. I appreciate it. And thank you, everybody, for staying here for the last session. And as Peter said, we have a new concentration in medical ethics. It's part of the biomedical sciences master's program, as well as an online clinical, or I guess I should say hybrid clinical ethics certificate program. So we want you to hopefully spread the news in your networks and grow the MacLean Center alumni and network of people. So we look forward to these training opportunities coming online. Thanks for staying for the last session. We have four great speakers. The topic or the title of this session is Clinical Ethics Decision Making. So our first speaker is Elizabeth Lanfear, who is a philosopher and clinical ethicist and an assistant professor in the Ethics Center at Cincinnati Children's Hospital and the University of Cincinnati. The title of her talk is Patient and Family Perspectives for Trauma-Informed Ethics Consultation, a Pilot Study. Elizabeth, welcome.
I think I might have won the prize for briefest bio if we're issuing those. So it's been a lovely weekend. I'm so happy to be here. Thank you for organizing such a fabulous conference, and thanks to those sticking around. So in the interest of time, I'm just going to get right into it. I have no relevant disclosures. We'll not be talking about anything off-label, but I do want to acknowledge my collaborators on this research, Sachka Singh and Danny Clark, who were really instrumental in the design, implementation, and analysis of the data in this project. So here's what's going to happen for the next few minutes. If you would benefit from being able to access your own copy of the slides to read along, you can do so with the QR code here. And so I'm going to talk briefly about kind of what trauma-informed ethics consultation and trauma-informed care are, at least on my view, my count. I'll describe a study that was designed to try to better understand patient and family perspectives that could inform trauma-informed ethics consultation. And I'll share a really small slice of our data because there's quite a bit of it, but I want to get to some key findings that might be interesting to you all. So we've heard about trauma-informed care a few times in the context of ethics consultation this weekend and other talks on kind of the account I've put forward in the literature with Uche Anani at Vanderbilt University. And to our knowledge, this is the first time the term was really entered into the literature. We were looking to combine the insights of trauma-informed care that's being widely adopted in medical practice. I work in a pediatric setting. There's an AAP policy statement and clinical technical report now on trauma-informed care. It's also being utilized in other clinical settings, also in non-clinical settings, which I think is really important to say. So especially in the context of clinical ethics, where we're not direct care providers, trauma-informed care is a tool that's being used in schools, in policing, in yoga teacher training. So there's a lot of ways you might do trauma-informed care that aren't in a sort of direct care role. And we were really interested in thinking about trauma-informed care as relevant to ethics consultation insofar as ethics consultations can be sources of traumatic experience for folks. They might be called due to traumatic experiences that are leading to conflict, misunderstanding, confusion, dilemmas in care. And they may be result in trauma or the situations that they're called in may result in trauma or re-traumatization for any stakeholder involved in an ethics consultation. So for patients, their families, but also healthcare workers, and something we didn't really explore, but I think is open to possibility, ethicists as well. So for the purposes of this brief presentation, I'm going to assume this audience is reasonably well-versed in clinical ethics consultation, that we can talk about maybe ways in which your models of it are different than mine and discussion if helpful. But I do want to talk a little bit about trauma-informed care, because this may or may not be a framework that folks are familiar with. So I do think about trauma-informed care as a framework, not necessarily, as I said, a form of direct care. It was originally developed by the Substance Abuse and Mental Health Services Administration, and it's sort of an approach that has 4 background kind of commitments and then has some set of principles that go along with it. So the background commitments are to really realize that trauma is common within populations. This is true in the national statistics about it as well as globally. So this is not a specifically US or North American phenomenon. And research suggests up to 70% of people, by the time they kind of reach middle age or adulthood, middle adulthood, have experienced at least one traumatic event in their lifetime. And when we're thinking about trauma in a trauma-informed way, it's a much more expansive definition than we might use it in psychiatric, psychological settings that kind of look at a particular objective event. It's really this understanding that people experience subjectively events, series of events, or maybe environments that disrupt coping mechanisms and have lasting adverse effects. And so the principles that then we want to, so again, sorry, go back to I realize trauma is common, recognize the impact of trauma, right, that prevalence as well as its signs and symptoms, respond with trauma-informed principles, and actively resist re-traumatization. And the trauma-informed principles are to focus on promotion of physical and emotional safety, to foster trust and transparency, to seek opportunities for peer support, to promote inclusion, to level hierarchy where possible, which is a big puzzle in healthcare, and to promote empowerment, voice, and choice, and then to pay attention to culture, history, bias, stereotype, contextual components that might undermine the enactment of those other principles. And so at this point, you're saying to me, well, gosh, Elizabeth, isn't good clinical ethics consultation trauma-informed already? And I would say maybe, right? My answer is going to be maybe. I think we know from the available data out there about how clinical ethics is done, at least in the United States context. We have a wide variety of models of clinical ethics consultation, a wide range of clinical and non-clinical backgrounds that are the people who are practicing clinical ethics, as well as a range of trainings and levels of experience that that are required of clinical ethics consultants or the clinical ethics consultants have. So on my view, I would say that things like ASBH core competencies for clinical ethics consultation are highly compatible with a trauma-informed approach, but they're not indicative of one. And so that's where there's a gap in thinking about how to be trauma-informed. So then we say, okay, great, I need to be trauma-informed. How should I do that? And I'll say, gosh, well, let's do a study. So one of the things that I think we really wanted to focus on in the study is, how I might think about, as an ethicist, safety or inclusion or empowerment in an ethics consultation may not be how a patient or a family member or another clinician or people in different clinical roles think about those concepts. So this study was really trying to start with patient-family experiences and trying to think about how we might use those to inform what could be a trauma-informed approach in clinical ethics consultation. So we were interested in testing a methodology where we recruited participants who had experience either as patients or caregivers of patients in hospital or chronic care histories, backgrounds, experiences. So they had some familiarity with medical systems and medical care. Hospital care probably didn't have experience with ethics consultation, although a couple of our participants did, interestingly. And we ended up recruiting 16 participants across 3 focus groups and did 2 follow-up small group discussions. We asked them to do a pre-read on clinical ethics consultation to give them some background exposure to what it is, again, assuming that this is going to be an unfamiliar concept to most folks. And then we tested a variety of cases, 2 case 2 cases per focus group with a clinical ethics consultation scenario to try to elicit feedback from participants about what would be safe or inclusive in those scenarios. And we chose safety and inclusion as the trauma-informed principles to focus on, given some data in the literature that those are 2 of the principles that are most important to both patients and to clinicians. So what did we find? And we kind of were interested because it was a pilot study and sort of the success of the project design as well as the content. So from a design standpoint, we had a series of process codes and when we coded our transcripts. And we found that overall, the cases generated discussion. They were mostly on topic, which is something we did code for. Participants self-reported that they were effective. But we also found that participants got stuck on the moral or ethical dilemma in the scenarios we raised, even though we were trying to prompt them toward making insights into the process of the ethics consult, not the outcome. Like we weren't asking them what the right outcome is in this situation. We're asking them for insights in how to perform the ethics consultation and their perspectives as patients or as caregivers. And certainly their limited information about clinical ethics consultation prior to the study and kind of familiarity with it was a drawback. And we had to use a lot of time to kind of unpack and explain ethics consultation and clarify questions. From a content standpoint, we found that overall the focus groups were successful in raising questions and suggestions that we think could inform clinical ethics training, also offered some potentially novel models for clinical ethics consultation. We found that overall, a lot of the things that participants raised aligned with existing both trauma-informed and clinical ethics best practice, which was helpful. That said, we often found that participants suggested roles or suggested activities or actions that are often performed by other roles in a hospital, which is not surprising given that they were familiar with maybe hospital care but not clinical ethics practice. They sometimes suggested things outside of the goals or scope of clinical ethics consultation. And while they were very good at identifying trauma-informed themes in their responses and kind of proposing themes that, as I'll show you, really align with trauma-informed principles, they had trouble making specific action or practice recommendations in the scenarios we provided them. So one of the ways we analyze our data is to sort of code for the overlap of these key trauma-informed principles that we were probing around, like inclusion and voice, with other key considerations that arose. And so I'm just going to show you some data about the highest areas of co-occurrence between inclusion and voice and the top co-occurring other considerations. And so we found that people most talked about inclusion and voice alongside ensuring that parties are informed, power and agency, seeking and sharing information, having choices or options, and patient input, which all, I think, go together nicely. So one representative quote, just to give you a sense of some of the findings here. And this was in a discussion around inclusion and voice. The participant really started talking about information access and sharing, and they said, quote, "I think voices involved in something like this, they have to be informed, because if they are uninformed or underinformed or misinformed about the outcomes of care or the options for care, that can lead to very drastic consequences, unintended or otherwise." And so the ethicist in me loves that for them, inclusion was being adequately informed, something I think we've talked a lot about this weekend is in shared decision making. So it was interesting to see kind of how they were conceptualizing that. When we look at the co-occurrence of safety and other considerations, the top other considerations they raised in the context of safety had to do with many of the things that overlapped with inclusion and voice. So one of them was, in fact, inclusion and voice, as well as power and agency, seeking and sharing input, patient and parent input. But they also layered on privacy as a really key consideration to understanding encounters or interactions, especially in ethics consultation, as safe. So one representative quote just about this is in the context of a case about a 15-year-old female who had a disagreement with their parent about HPV vaccination. And one participant said, "It's always good to find out if the 15-year-old was comfortable once the doctor explained their dilemma and then say, hey, are you comfortable with us having this conversation in front of your parent, or would you like to do it separately?" So really thinking about including them in decisions around privacy and safety and participation. So one of the key findings for us then was the idea that really safety and inclusion and voice are kind of co-constitutive of each other. So inclusion requires a sense of safety, and safety can be inclusive. And our findings also just overall suggest that trauma-informed principles mutually support and reinforce each other. They're not necessarily easily isolatable as a single kind of, I'm going to enact one of these now. So at this point, you might say, okay, so what's an ethics consultant supposed to do about any of this? Again, as I mentioned, our participants had a hard time coming up with specific practice suggestions, which is not surprising given their background unfamiliarity with what we do in clinical ethics. But they were able to identify, again, some themes that I thought were helpful, that were most important. So these were exploring creative options, managing expectations, fostering inclusion and voice, and attending to power and agency. And those were things that they, throughout all of the cases, saw as important roles and functions for the clinical ethicist. And I think that what's interesting here to me is when I look at this list, it really aligns with, again, trauma-informed principles. There's a strong overlap. So, on the whole, we see that trauma-informed themes and principles permeated the focus group discussions, even ones we were not probing or introducing into the discussion, and shaped what was most important to our participants when presented with ethics consultation scenarios. Yet they struggled to offer specific practice suggestions, and there was some internal disagreement, sometimes even either across cases or in the same case, regarding what was trauma-informed, and this often reflected the participants' own sort of situated identities. So people who had a lot of experience as caregivers for a pediatric patient maybe had different views about privacy, inclusion, patient inclusion, than people who were adult patients or had experience as a patient themselves as a pediatric patient. And maybe had a different standpoint on kind of what would be safe or inclusive in those situations, which just I think is to say how much this needs to be tailored to the situation and the stakeholders. But I think from that, we can see that, in my view, these data affirm the idea that trauma-informed care can be a framework for practice and one that can be action guiding, even if it's not a strict checklist of what to do in any or every case. So it's not the same maybe as performing a trauma-informed physical exam and a well-child visit, right? It's quite distinctive, but so is ethics consultation in many ways. But we do think that the way trauma-informed principles permeated what mattered to our participants suggests that knowledge and attitudes about trauma-informed care are relevant to ethics consultation and should be part of its standard training and competencies. All righty.
Great talk. I'll open the floor for any questions. So, Elizabeth, could you give us a little bit more, and I apologize if I missed it, so these participants were 18 and older.
Yes.
Were they patients or were they recruited from the community? And then could you tell us a little bit about the cases they were shown?
Yeah, so I do have a slide with the cases. So this is a summary of the different cases we gave them, and they could sort of reflected different requesters of ethics consultations and different kinds of ethical questions. So again, I mentioned a conflict between an adolescent and her parent about HPV vaccination, a question about whether a patient who was an adolescent would want her ventilator discontinued, given her quality of life, a question about an exception to a hospital visitor policy. So a range of kinds of scenarios. Some were initiated by physicians, social workers, some were initiated by parents. And to your question about our participants, so they were recruited primarily from a few areas. We had outreach to our hospital, patient and family advisory board, but also some other kind of medical communities and medical humanities communities looking for both patients and caregivers. And so they were 18 and over for reasons related to kind of consent and IRB for a pilot study. But the hope was that they had some direct experience, either being the direct caregiver of a patient or having been a patient themselves. So they had familiarity with hospital and health systems, maybe kind of expert patients.
Thank you for highlighting this missing but needed quality in ethics consultation. Your last slide, could you say a little bit more about ethicists being the moral designers of morally habitable spaces throughout TIC as you explain it?
Yeah, so this is building, for those of you who are familiar with sort of the language from Margaret Urban Walker, thinking about ethicists as architects of moral space, right? And they're kind of like creating, like holding and making that moral space in clinical settings. And so the way Uche, my collaborator, and I have been thinking about trauma-informed practices is it really sort of designs that space and to make it, as we think about it, this morally habitable, like it's livable, it's safe, it's inclusive. Like it's not just enough to hold the space or create the building, but how are we going to design the interior in a way that's accessible, inclusive, safe, supportive, et cetera. And so we're thinking about that kind of layering on of trauma-informed awareness and practice as one way to design that interior. So yeah, thanks.
Thank you.
Thanks so much.
Okay, thank you. So our next speaker is Priya S. Tarsney. She is the director of the Donnelly Ethics Program at the Shirley Ryan Ability Lab, where she has worked for over 13 years. She is an assistant professor in physical medicine and rehabilitation at Northwestern Feinberg School of Medicine. Priya is a lawyer by training who practiced in the Chicago area and then followed her interest into medical ethics, completing a clinical ethics fellowship at the MacLean Center for Clinical Medical Ethics in 2010. Priya's interests in bioethics include informed refusals, negotiation and mediation skills for clinical ethicists, dignity of risk, decisional capacity, and best practices in ethics consultation. She is a clinical and research ethics consultant and has been involved in multiple ethics teaching endeavors, including simulations and courses at Shirley Ryan Ability Lab and beyond. Priya enjoys presenting on and publishing in the areas of disability ethics, clinical ethics, and rehabilitation ethics. The title of her talk is The Ethics Case for Promoting Best Practices in Decisional Capacity Evaluations, a Disability Ethics Focus. Priya, welcome back. Good to see you.
Thank you so much for that nice introduction. It's great to be back and to be with you all today. So I have no disclosures, and these are some of the objectives that we're going to cover today, talking about some of the ethical tensions that arise in the status quo with capacity evaluations, looking at some of those unique vulnerabilities and issues for people with disabilities, and then discussing a model that focuses on developing best practices and facilitating real organizational change in capacity evaluations. So the status quo, this is something that many of you are familiar with, so I won't spend too long on this, but as you know, decision-making capacity is the ability of a patient to make their own medical decisions, primarily consenting to or refusing specific medical interventions. And although it's sometimes referred to as medical competence, I'm going to use decision-making capacity in this discussion, and I think that's been really helpful to be consistent about in our setting because sometimes this can be confused with legal competence, which is more of a global, broader assessment by a judge, whereas decision-making capacity is really done and performed by clinicians in the clinical context. So as you know, it's got roots in patient rights and informed consent. It's fundamental to this and respect for autonomy. And it's decision-specific, time-specific, so it's dynamic, as well as there's the sliding scale, so patients have to have greater capacity in order to make a decision that has higher risk and less capacity to make decisions that don't carry as great risk. And as you know, the Applebaum and Grissot's 4 criteria is typically considered kind of the gold standard, though there are other tests for decision-making capacity, certainly. But, and I've laid out here some of the 4 criteria: communicate a stable choice, understand relevant information, appreciation of the consequences, and then reasoning, that weighing of risk benefits. But I love this particular graphic because it shows you all of the biopsychosocial factors that really do weigh in when we're thinking about evaluating for capacity, and also the interrelation between these 4 criteria and how there's overlap naturally as we are really thinking about this and whether the patient is able to demonstrate this. And I want to point out and just really emphasize the consensus that exists here in the law and in ethics, which is that there is a presumption of capacity, right? So that means that we need specific evidence to refute capacity of our patients, of these individuals. And the literature is pretty clear on the fact that we really need to provide specific rationale as to where they fall down on these criteria. If they do not have capacity for a specific decision at that time. And there's a lot of good discussion about how this should really be clear and convincing. And so in the law, when we think about standards of burden of proof, this really relates to me as clear and convincing evidence that there's a lack of capacity in one of these domains, right? So that's important because we really want to preserve and respect autonomy, and we want to, really watch for that unintended or irreparable harm. But the best way to balance that respect for autonomy and beneficence is to have that strong and clear and convincing evidence. So these capacity assessments are really important, and it's important to do them robustly. Unfortunately, there's some concerns with the status quo, right? There's variability in the nature and quality of capacity assessments, as well as inter-rater reliability issues that's really been documented in the literature. This is understandable as there's no one test of capacity, right? Though these 4 criteria that I focused on are critical. There's no one test, and it naturally involves subjective clinical judgments about this. It's a decision about a decision, right? So you can see how there's some natural variability that's going to occur there. Then there are really concerns to layer onto that with the adequacy of training and education. In one survey of psychosomatic medicine clinicians, those clinicians reported receiving subpar training with relatively weak evidence as compared to other types of assessments that they are completing. And other studies have really endorsed room for much improvement in the education and training realms of conducting capacity assessments. So there's room for greater training in this realm. There's also a lot of questions that emerge on what to do in cases where there's probable capacity or marginal capacity. And this can really be true because there might be, issues maybe in appreciation where there aren't issues in other realms, say, of the capacity assessment, right? So that's something that clinicians raise who conduct these particular evaluations, as well as concerns with adequate value exploration. And I think the presentation we had yesterday really spoke to this, right? The idea here is to look at the decision-making process, not the reasonableness of the decision, right? Not the outcome, but the actual process. And so one of the critical things to do as we are conducting these capacity assessments is to look at the values that that patient holds dear and how that factors into their thinking. And then there are a lot of myths that dominate in this space. I'm sure many of you clinicians have seen in charts, patient lacks capacity. Capacity for what, right? So it needs to be specific to the decision and at that time. And obviously, the hope is that there's more of the specific rationale that's contained in there. But sometimes there can be that collapse into this all or nothing thinking when it comes to capacity. And that's something that's, needs to be watched for in this space. There's a lot of documentation, too, in this article about the 10 myths, noted this years ago, and it's still something that's talked about in the literature, that many people aren't provided the information before their capacity is assessed. So if they don't have that fulsome informed consent conversation, right, where they're getting the risks, benefits, and alternatives, and they have a capacity assessment prior, they're unlikely to demonstrate that capacity. And in the rehab context where I work, this really does come up quite a bit because we note that oftentimes people come over from acute care and their surrogates have been the ones who've been receiving a lot of the information. The patients haven't received a lot of that directly, or they're receiving it from their surrogates, which isn't a direct course of communication for them. So those are some of the issues. And other questions abound, such as what standards are best? Some authors have argued for a different approach to things like residence capacity, or what we call in our setting discharge decision-making capacity, or the capacity to designate a surrogate, people argue that that's a much lower standard and threshold, and that should be separated out from all these other decisional capacity evaluations. So there's, a lot of questions about this, because I think there are many concerns about not holding people to too high a standard. And there are also concerns about really respecting patient preferences and beliefs in the course of conducting these capacity assessments. We know that if someone doesn't have capacity, it's not like they lack agency, right? And so a lot of questions come up about, well, what do we do next when those situations occur? And, common capacity scenarios really encompass people with disabilities, right? These come up often, it commonly arises. And that can be true because, at our hospital in particular, we see people who might fit multiple of these categories, right? People with acquired brain injury, people with serious mental illness, people who refuse treatment or professional advice. This is something that's been documented in the literature as being a common cause of requests for capacity assessments. So those are things to really be mindful of. And certainly this really does encompass and affect commonly people with disabilities. And beyond the common occurrence, what about disparities for people with disabilities? There's been documented racial disparities that exist in the decisional capacity realm. And of note, this is both that they are requested, there's more requests for capacity evaluations for people due to race, as well as the outcomes of those capacity assessments being that they lack capacity, and that's being seen more often. And as we know from Dr. Kirshner and others who've presented on this, there's the disability paradox, right? So this includes clinicians who often, view the quality of life of people with disabilities as much less than those people with disabilities would rate their own quality of life. So these are concerns and really raise the question about particular disparities that are coming up for people with disabilities in this space. There's a gap in the literature here. I can't find any documentation of disparities. It'd be great if we had some more of that data to understand that well, but that hasn't clearly been studied. I worry a lot about the burden of proof shifting to people with disabilities having to prove that they have capacity in some of these realms, and so that's a real concern. So when it comes to assessments, one model that fits within the disability ethics framework is centered on the lived experience with people with disabilities is to use an inclusionary, multidimensional approach to capacity. This recognizes the importance of the social model of disability that looks at what barriers can be removed, right? What supports need to be put into place. It views the capacity assessment as less of a test and more of a true assessment to see what decisional supports would be valuable. So it often requires this multi-step approach and acknowledges the capacity a person has and builds up from there. The dignity of risk doctrine also promotes a more supportive, multi-dimensional model of decision-making capacity assessment. And dignity of risk involves honoring patient choices involving risks, even when potential harms exist. It recognizes the human experience of risk-taking and in day-to-day life. And Persky and others who first coined this term spent their time really promoting inclusion of people with disabilities into their decisions, which includes decisions involving risk-taking, right? That engagement is a basic part of extending human dignity to people with disabilities and including them in those kinds of decisions. And Brian Chacon and Christy Kirshner have a great quote here that kind of articulates this guiding principle in their discussion regarding supports for people with intellectual disabilities, that care must be taken to avoid shifting from the extreme of paternalism on the one end to the neglect of insufficient or inappropriate support on the other. And this is critical because there are really unique harms that can come about for people with disabilities who are judged to have lost capacity to make certain given decisions. There's the loss at the micro level, right, for the individual, loss of decisional authority as it relates to that decision, and that can lead to further marginalization, really a strained therapeutic alliance, psychological distress often for people. And there are also macro level losses to really be aware of here. I've seen this in our setting, and it's really hard to say this, but sometimes people will say, well, patient needs a guardian, so we need a capacity assessment. which is a really backwards way of getting at this, right? And oftentimes these capacity assessments are, the key evidence in these guardianship proceedings to show that patients aren't able to make certain specific decisions and that this should extend then globally. There have been a lot of legal reforms in this space to try to, bring more to bear in those guardianship proceedings, but I think there's a lot that can be done to evaluate what capacities does the patient have, right? So that you don't have to jump to a full guardianship, and then also to evaluate whether other models might be better for the patient, such as supported decision making. Could they name a supporter to help them in making certain decisions? This can be critical, and right now, different states have different laws on this. In Illinois, this was passed in 2022 and really applies to people with intellectual or developmental disabilities, enabling them to name a supporter and to retain their rights to make the decision, but to have the supporter help them with specific aspects. So those are different models that can be utilized as well and are important for us to know about. So from a disability ethics standpoint, I think these are some critical factors to focus upon, right? Looking at the capacity profile, making sure it's individualized, not assumed. What capacities does the patient have? Do they have capacity to designate a surrogate decision maker? And revisiting and restoring capacity where feasible, where this is likely. Is it possible to wait? Is there additional time until a decision needs to be made? Can we revisit this? Especially if they're showing partial capacity or there are questions about marginal capacity, this is important to look at. And then really the tools and supports for demonstrating capacity, making sure those are in place prior to the capacity assessment. So addressing communication barriers, providing cognitive and/or communication supports as needed. This might be, memory aids. It might also be partnering with a speech-language pathologist, like is done in our setting, so they can provide the communication supports during that capacity assessment, so the patient's able to understand information and also to provide information back. And then harm mitigation, really reducing the chances for capacity to be overridden, both short-term and long-term, looking at inclusion of patient preferences and perspectives. If we are documenting what their values are, even if they lack capacity for a certain decision, that can be included in a shared decision-making, bringing that to their surrogates later, right? And if there are certain places where they're really struggling, those can be areas where maybe their surrogates can assist them, and they can participate in making that decision alongside their surrogate decision makers for a more fulsome, true shared decision. Also recognizing, this patient participation and partial capacity, like I mentioned. So we talk often in ethics about, how to make an impact and a difference. I think ethics can really be a voice in fostering these best practices within the capacity realm, especially for people with disabilities. And, I do really think there's a collective action issue in this space. A lot of people recognize these deficits with decision-making capacity evaluations and some of the problems, but who is going to be the person or, take the lead on trying to establish some of these best practices? I argue that ethicists are really well positioned to be able to do so. One model of capacity is one that we use at our institution, and we're now in kind of our third iteration of this. And this has really shaped my thinking on this a lot, and, especially about the role of an ethicist in this space. So we have a capacity group at our institution, and that is a multidisciplinary group that involves psychology, psychiatry, ethics, and speech-language pathologists. And we have a board-certified neuropsychologist who's responsible for triaging that capacity group for the intake of the capacity requests that come in, and then finding the best service possible to be able to complete the capacity evaluation. We use the standardized structural approach, and we use this consistent approach to documentation. So when our clinicians request a capacity evaluation, they should be getting a consistent result in terms of the feedback as well as the documentation of this. And we meet quarterly to dialogue about best practices, bringing forth the best that we can find in the field and talking about really difficult cases that have come up, capacity assessments that have come up, to see how it is that we can do better. And typically, our capacity evaluations in this model have been completed by more than one discipline. And co-treatment has been our standard model for patients with aphasia. So utilizing a speech-language pathologist who can support communication directly alongside the evaluator during the course of capacity evaluations for patients with aphasia, also patients who are locked in. There's a lot of patients who could use some of that communication supports. So I think it's ideal for ethics to be a partner on a capacity team and find a role that really fits or suits you. Perhaps you have the requisite training and ability to co-conduct some of these assessments or be the ethics partner alongside an evaluator during the course of some of these capacity evaluations. At our institution, we utilize this two-consultant multidisciplinary model. I know it's not possible or feasible in lots of contexts. I recognize you need training, and I benefited from being trained by a neuropsychologist in this particular space. And then you need to know, it needs to be really carefully considered given the state laws that you have. It also needs to be very carefully executed, given your role in specific cases and your scope of practice. But it's something to truly think about as you consider what role might be best. Or perhaps actively promote those best practices alongside others in a working group where you're looking at some of these challenging cases that are arising and thinking about how your organization can do better. Maybe more standardization, maybe it's additional training because you've discovered your clinicians find that they're not feeling as capable as they wish to be within this space. And then really attending to the relevant disability accommodations that I mentioned earlier, those supports so that people they are able to demonstrate the capacity that they have. So truly being an active and not passive participant in these capacity groups. I want to focus a little bit on what you could do if you're a part of this capacity group just by way of intake. So say you're not comfortable, being alongside somebody during the course of a capacity evaluation. There's a lot that can be done on the intake side of this. And this is similar to what we do when we're, consulted for ethics, right? And we're doing that intake and getting, understanding the stakeholder perspectives, information in the chart. So really looking at the capacity, what are the cognitive concerns? Where are the gray areas, strengths and weaknesses? Interpersonal dynamics that are factoring into this, right? What are the supports that are needed? And then ensuring that that requisite information has been provided to the patient before the evaluation so that it's truly necessary and that the patient's in the best position possible to demonstrate their capacity. I will tell you that as part of the capacity group, when I get involved in the intake part of this process, a lot of the capacity requests go by the wayside on this last point, because we discover that patients haven't really been provided that information directly. We don't know what their concerns are, or maybe it's really not clear where the gray area is. And people say, you know what, I'm going to go back and have a fuller conversation with them and really come back to you if this is needed. It might also be possible for you to adopt a role where you're designing that policy and practice, right, to address the issues that you're seeing within your institution. So again, informed by those best practices. And I would really encourage, because of the disparities and the issues for people with disabilities, the equity issues, that you really think about what is needed for people with disabilities to demonstrate capacity in your particular setting. So perhaps that's developing practice guidelines or policies to promote those equitable capacity evaluations at the organizational level, coming up with that working group, right? Or designing a process that checks and balances where if physicians are given a guardianship request, then maybe they also encourage the family to speak to others, speak to ethics, find out what their options are, or evaluate lesser capacities of the patient to then bring that information back before the family. And then look for opportunities for preventative ethics in terms of training, education, really. We talk a lot in our capacity group about where we can do better and then bring that back to the clinicians. And then, perhaps even greater opportunities for collaboration, right? In the public policy domain or otherwise, and, thinking about those advanced capacity practices that might be best designed. I think ethicists are really well positioned to change these practices. We solicit values regularly, right? We can teach others how to do this in the course of their capacity evaluations and the importance of doing so. We often are charged with this role of employing best practices, right? So that we can advocate for those at the organizational level and beyond. And there's a real rationale for doing so because of the equity concerns. And then really, where feasible, assist with supported complex decision-making. So whether that's encouraging your clinicians to include patients in those follow-up conversations, or you yourself offering to be available to facilitate conversations with the patient and their family members for that shared decision-making, that could be helpful as well. So I just want to lift up some of those pieces. I know that, Christy Kirshner and Debjani Mukherjee and I asked in our Hastings Center article, if not now, then when? And I really think this very much applies within this capacity space as well. It's time to make strides in the capacity realm toward disability justice, and ethicists should find a role that fits them and their organizations in that endeavor. Thanks so much. Oh, and thank you specifically to my colleagues as well as my mentors.
Priya, thanks. That was a really great presentation. I'm struck by the fact that tends to be a double standard in that we question someone's capacity when they disagree with the recommendations we make, and we go along with them when they agree. And so clearly this multidisciplinary capacity assessment is a very time-consuming process that appropriately, acknowledges the complexity. What I'm curious about is what are the triggers for when you actually engage in this? Is it only when people disagree with something that the care team is recommending, or do you say, we're just not sure that this person who is going along with everything we're recommending really has the capacity to make those decisions?
Yeah, that's a great question. And I think doing more education in this realm can help clinicians figure out when they should raise their hand, to request a capacity evaluation. I mean, attending physicians can complete these, right? They don't need to really call on a specific service to do it. But we do try to, I do find that people request these when there is a refusal, right? Or the patient's disagreeing with the recommendation. And I think being a part of the capacity service, asking a few well-placed questions can really help to determine whether it's needed at this time.
Thanks.
Yeah, thank you.
Hi, thank you so much for this. This has been really helpful because I think as a geriatrician, as well as on ethics, this idea of anyone can perform, any of the medical providers and the team members can perform this, and talking about the training and education perhaps not being adequate is something really to keep in mind. So I'm always torn on not becoming the folks who just have to do every capacity assessment in the whole hospital, but then also feeling really strongly about people losing the ability to make their own choices. And so I think the ethics or the capacity group is fantastic. And my first question is, how is the capacity group, how's it triggered? How does that consultation happen? And then my second thing, and I'm a little bit nervous because I'm trying to interpret a law to a lawyer, but I think that in our Surrogacy Act in Illinois, it does state that when we determine that make the assessment that somebody lacks capacity, it does state in the act, is my understanding, that you are supposed to inform the patient that they have been deemed to lack capacity, and then inform them who their surrogate decision maker is going to be. And they are allowed to answer that and refuse it, and then that should prompt an evaluation of their capacity to choose in that moment. And I'm wondering if somebody can't, if an institution can't necessarily start an ethics or a capacity group right away, because I think it's a great idea, is there a place for that moment to ask, to the patient, you have the ability to have a second opinion if you wish? Is that a time to then trigger some other specialists who may be able to help in the capacity assessment, allowing the patient to ask for that?
That's a great question. I mean, I have seen situations, to answer your second question first, I have seen situations where patients have asked for a second opinion on that capacity evaluation, and then a different discipline has completed that. So that's feasible. I've also seen opportunity then to see if they have capacity to designate a surrogate and then who they would choose, right, if they don't like that particular surrogate. And then we can take their preferences into account, right, in terms of that surrogate decision making, at least here in Illinois. But on your first point, I really think, I lost it. Your first point was about what triggers it. Yeah, I mean, in our setting, we educate people about this and that it shouldn't be done for every patient who's, not complying with or doesn't agree with the recommendations, right? And that it really needs to be done when there's uncertainty about whether the patient is understanding and appreciating, the choices before them. So we sort of educate about that. So sometimes it's triggered to our capacity group via an email group that goes to the assessors, and then the psychologist does the triage, and does most of the intake. I assist with the intake often, or our ethicists do, where feasible, but we'll ask questions back, and there's sort of an iterative intake process. So I think it's really, what I'm suggesting is a bit of a procedural solution to address some of these various concerns that we find, and then hopefully move the needle on the culture around capacity. And I recognize that this particular solution is very time and resource intensive. I would also emphasize that it really preserves a lot of the preferences of our patients. It enables them to actively participate in decisions to the extent that they can. And I think because of all of the constraints in our systems and ableism that exists out there, in my mind, it's a must for people with disabilities. Too often I've seen people who have communication impairments be, really cast aside and their voice really not being heard in terms of their own decision making. And oftentimes they, are able to make their own decisions with the right communication supports. And so we actually developed further training in our setting alongside the speech language pathologists and others for how to conduct these capacity evaluations for patients with aphasia. And that's where we came up with this standard of co-treating alongside speech language pathologists as a routine measure when we have patients who have aphasia and also other communication impairments. Thank you.
Thank you. Our next speaker is Mary Simmerlin. She is a scholar, poet, and social justice advocate. She holds a PhD in philosophy from the University of Illinois at Chicago and an MA in psychology from Adler University, and is on the faculty of Cornell University's Medical College. Mary is active in a number of nonprofit organizations in the US and Canada. She is a member of the League of Canadian Poets and serves on the board of Amherst Writers and Artists. As the senior research advisor to RAINN, Mary has played a pivotal role in advancing national and international initiatives for survivors of sexual violence. The title of her talk is Illuminating and Easing the Human Dimensions of Caregiving Through Facilitated Writing Workshops, Findings from Year One of the Caregiver Project. Well, Mary, welcome.
Oh, he's taller than me. Good afternoon, everyone. First, I want to say this is such an incredible conference, and over the last 3 days, I have found that excitement I had 20 years ago when I applied to be a fellow. It's right back again, and I love it so much. So I want to thank Dr. Mark Siegler, Dr. Peter Angelos, and Rachel Kohler, the trustee. I'm so happy to be here. This afternoon, I'm going to share with you some of the findings from the Caregiver Project, which is part of Amherst Writers and Artists' Power of Story initiative, which aims to illustrate and ease the ethical, emotional, and social complexities faced by professional and personal caregivers. This project brings to light an often critical and overlooked dimension of healthcare, one deeply interwoven with clinical ethics and social justice, as caregivers frequently confront immense challenges with little support or recognition. And I think we heard that really, really clearly earlier today from our prize-winning speaker, Dr. Solomon, who talked to us about how families are being left alone to provide this work on their own. I have no financial disclosures, and the work was funded by Amherst Writers and Artists, which is a nonprofit. I'd like to acknowledge my collaborators, Gail Cunningham, Carla Hansen, Beth Lehman, Sue Reynolds, Meadow Jones, who's here with me today and will be presenting with me, answering questions, and Susan Wingert. So I included this quotation from Rosalind Carter because I think it's a really important reminder that all of us will either need or become caregivers at some point in our lives. And I know most of the people in this room are professional caregivers and may also be personal caregivers. So caregiving, whether for family, friends, or patients, is, I think we all agree, a grossly under-resourced yet essential public health and social justice concern. Today, roughly 25% of Americans, or 1 in 4, provide unpaid care for loved ones affected by chronic illnesses, disability, or age-related declines. This burden often falls disproportionately on women and individuals from marginalized communities, exacerbating issues of isolation, burnout, and moral distress. This data is from 10 years ago. 10 years ago, it was estimated that the value of informal caregiving was $470 billion, which at the time exceeded home care and Medicaid spending and was roughly equivalent to the value of Walmart. In the absence of adequate resources, caregivers face compounding emotional, economic, and ethical challenges, often feeling invisible and unsupported in their roles. They experience mental health strain, heightened levels of anxiety, depression, and stress. They are often isolated and feel invisible due to the nature of their roles. They frequently lack social support, and this leads to feelings of invisibility and lack of recognition. And I said earlier, the challenges of caregiving weigh more heavily on women and marginalized communities. This infographic really helps to highlight caregivers' feelings. They feel exhausted even after they rest. They feel frustrated and resentful sometimes of the care for the recipient, which I think really causes moral distress to them often. They feel like they are not doing enough. They feel inadequate. They feel helpless and trapped, and they experience difficulty just doing the regular activities of daily life. So, in response to this, in 2022, Amherst Writers and Artists launched the Power of Story project, which the Caregiver Project is a foundational part of. The Caregiver Project seeks to provide a space where caregivers can come together in community to write their stories. Through this project, our hope was to provide a safe space to transform caregiving from an isolated endeavor into one of shared reflection, validation, and connection. Within this framework, the Caregiver Project was established to create safe spaces where caregivers could process their experiences through facilitated writing workshops, helping them to reclaim their voices and find the community in the company of other caregivers. So today, I'm going to share with you the findings from year 1 of the project, which reflects Amherst Writers and Artists' commitment to using the power of storytelling to address pressing issues in caregiving. At the heart of the Caregiver Project is the Amherst Writers and Artists method, which is a structured yet flexible approach to expressive writing. It emphasizes autonomy, boundary setting, and communal support. The Amherst Writers and Artists method differs from other expressive writing approaches in its commitment to respecting participants' control over their engagement. As you can imagine, caregivers often feel like they don't have control over that part of their lives. Caregivers can choose to share their writing in the group, reflect privately, or engage at whatever level feels appropriate for them. And this flexibility is really vital given that caregivers often have limited agency in other areas of their lives. AWA's method is built on a set of principles and practices designed to create a safe environment. We have some essential affirmations for an AWA workshop. Number 1, everyone has a strong, unique voice. Number 2, everyone has creative genius, no matter their education, economic, or cultural experiences. Writing as an art form can be learned without damage to a writer's original voice or artistic self-esteem. And my own personal favorite, A writer is someone who writes. There are 6 essential practices. We maintain a non-hierarchical spirit, and we have a model built on practices to create a safe environment without imposing expectations of disclosure or vulnerability. Trained AWA facilitators participate as equals in the workshops and in writing and sharing their work. This reinforces a sense of shared community because the leaders write alongside the caregivers. The egalitarian approach removes hierarchical barriers, allowing caregivers to engage with fictionalized or crafted narratives rather than personal testimonies. Essentially important is that the feedback given in the workshops focuses on the writing as a craft, and the feedback is related to what is strong in the writing. We do not focus on the writer, we focus on the writing. And this approach has been essential in establishing a space where caregivers feel both empowered and secure in their self-expression. I'll just note on this slide that the equality of the participation by the leaders is really important because it sets an equality of risk-taking and establishes mutual trust. The core elements of AWA methodology in the caregiver workshops are expressive generative writing, which fosters reflection and connection among caregivers within a supportive community. Participant autonomy, caregivers can choose how to respond to prompts with the option to share their writing or reflect privately. There are safe boundaries, so the discussions center on the story rather than the personal experiences, and this really creates an ethical boundary. And then we give constructive feedback, focusing on what is strong. So, in year 1, the Caregiver Project conducted 2 multi-week sessions and 32 individual workshops with 66 total participants. Participants were invited to complete brief pre- and post-workshop surveys as part of our program development and improvement. All workshops were held over Zoom to meet scheduling needs of caregivers, and each session adhered to the AWA framework, incorporating open-ended prompts that allowed participants to focus on whatever resonated with them at the time. The flexibility offered caregivers a chance to recenter on their experiences, a brief but significant respite from the demands of caregiving. And I'll just say that the facilitators are also caregivers for these workshops. And let me just share that in many of the workshops, the caregivers who are taking part were either joining from the infusion center where their partner was getting a treatment, or they were joining on a brief break they had. And so it was really wonderful that we had this flexibility and everyone knew we had this flexibility. In addition to supporting professional and family caregivers, we also expanded our workshops to a very distinct group of caregivers, and these are the volunteers and staff of the Rape, Abuse, and Incest National Network, National Sexual Assault Hotline, who provide round-the-clock support to survivors of sexual violence. This group of caregivers often operates in isolation, and they experience secondary trauma without avenues for emotional processing or community support. Given the 24 nature of their hotline, the workshops were structured as standalone sessions to accommodate the demanding and unpredictable schedules they have, and allowing them to participate without interfering with their work commitments. For this particular group of caregivers, the AWA model proved very effective in offering a protected space to process the emotional weight of their work and connect with peers who share their unique challenges. These workshops created much-needed community where they could engage without risking confidentiality or professional boundaries. So our key findings from year 1 are that reveal that structured, community-based writing through the AWA method is a powerful tool for fostering emotional validation, reducing stress, and mitigating the isolation that is inherent in caregiving roles. The open nature of the prompts, along with the choice to share or reflect privately, gave participants a vital sense of autonomy, validating their experiences without pressuring them to share more than they were comfortable sharing. And this freedom allowed them to explore and process their emotions within a communal framework, offering an experience that contrasted sharply with the usual isolation they experienced. Caregivers across both groups reported experiencing a deep sense of relief and connection through the workshops. They felt validated and seen. One participant noted, "For the first time, I felt like I wasn't alone." And this sentiment underscores a prevalent reality among caregivers: the urgent need for connection and recognition in a community that understands their unique challenges. The Caregiver Project's findings also echo research on the importance of emotional validation, mutual understanding, and a sense of community. Our model's communal, non-hierarchical structure, grounded in respect for autonomy and shared control, provides an ethically sound model for caregiver support that mitigates the pressures of disclosure while enhancing the benefits of expressive writing. For the National Sexual Assault Hotline volunteers and staff, the workshops offered essential relief. They actually said it was the most important thing that was offered to them in support of their work. And they found in it a way to reflect and process secondary trauma among peers who understand the nuances of their work without compromising confidentiality. Through our unique approach, AWA supports caregivers in reclaiming their voices, validating their experiences within a trusted community. This ethically grounded framework provides a flexible, inclusive space where caregivers can explore complex emotions and connect with others who understand their roles, the unique demands of their work, and without having to worry about being subjected to questions or critical feedback. So moving forward, we are planning to expand the program. We want to continue to evolve, reaching more caregivers in diverse settings. Our flexibility and commitment to ethical practice offers a scalable model that can be adapted to different caregiving contexts. And as we expand this work, we're committed to gathering feedback, refining our methods, and advocating for the integration of similar workshops into broader caregiver support systems across healthcare and beyond. I want to invite you to join us for a caregiver workshop if you're interested, and also to submit your own writing about caregiving for our anthology of caregiver stories that we'll be publishing next year. And I'll share that information with the MacLean Center, and it can be shared with you. So I want to share this quotation from Pat Schneider, who developed the AWA method. Pat said, "When we write, we create. And when we offer our creation to one another, we close the wound of loneliness and may participate in healing the broken world. Our words, our truth, our imagining, our dreaming may be the best gifts we have to give." I'd like to close with a poem that was written in one of our workshops by Hannah Kuhn. It's called Mending. Mending. Come now, my brother texts. Across an ocean I fly to her bedside. Dutiful daughter, come to fix the unfixable. Bind up her wounds, bearing chocolates and orchids. All the while denying what is broken beyond repair. Not the knee, smooth titanium bends beneath a knotted pink scar, better than new. But her mind, her zest for life, withers a dry leaf in a cold wind. Some things cannot be healed. 4 years pass. The broken bits of my heart still throb, still ache with her absence. Now it is my dad, aging like a wild salmon, turning colors, growing a hooked beak as he struggles upstream to the source, a burst of fierceness before the end. This time, his dutiful daughter steels herself, fights the lure of fixing, leaves space for her brothers to step forward, to mend the world if they can. Skill biography. Thank you. I know Meadow's willing to take questions too. We'll be happy to answer any questions. Thank you so much.
First,
Yeah, come on, Meadow.
please. These people are taller than me too. Mary and colleagues, thank you. I was a personal caregiver for years before I am working to become a professional one. So thank you for your project and presenting it here. I think it complemented the previous presentation extremely well. But my question is, can you please speak more to how caring as a personal caregiver, as our system leaves us to care, results in the severe loss of sense of self and re-traumatization the personal caregiver may be subject to in the way the professional caregiver can distance themselves from?
You want to take that hard one?
Oh my goodness, it's a really big question. Thank you for asking it. Also, Mary, good job.
Thanks. Go
This
ahead.
was a good job. So, I think you're asking this because you have a lived phenomenological experience with it. And many of us do. So there is research that maybe points to that. But what we found is that that narrative emerges while we're working with people. So of course people are alienated from their work, from their work as caregivers. We become the labor itself. And I mean, all I could do is speak to my own experience, which is that all of my work has to fall away because nothing matters but attending to the illness and the injury at hand. And that's very different than the work we're paid to do. I mean, there's also, as you know, a high level of burnout amongst professional caregivers, empathy decline in medical school, high rates of suicide even. So it happens there, but when we live it day to day without much support, there becomes isolated pain, and pain becomes unbelievable, and sharing it with one another is an intervention. Does that answer the question? Because it's a big one. I want to write it down and research it.
I'm going to add one more thing, and that is that in many of our workshops, we had people who were both professional caregivers and personal caregivers. And so we had a mix. We did not separate the groups based on whether people were providing personal or professional care, except the National Sexual Assault Hotline group was its own group.
That's right.
So I probably have a much simpler question, and you actually sort of got to it a little bit at the end, but I was wondering the whole time about how you think about scaling this and expanding it. Because on the one hand, I heard you using Zoom, but then I also heard that it's leadership intensive, there's confidentiality issues, and so how scalable is it? Is it something you want to scale, or is it something you say, you know, we want to keep these smaller groups, maybe we want to have lots of smaller groups? So how are you strategically thinking about what the next steps are?
That's a great question, and we do think about this all the time. We actually meet as a committee every week or every other week to work on these issues. So what we did in the first year is, like I said, we had these standalone workshops, and then we had the series. And with the series, we have a better sense of how many people we're going to have taking part in it. And we close registration 24 hours beforehand. So there is a cadre of facilitators who are also caregivers who are ready to lead these workshops. What we have found is that we can have as many as 50 people join a workshop, and then we pre-plan that we will each take a certain number, no more than 6 to 8, in a separate area, a separate breakout room. So we'll all come together, we'll write together as a group, and then we'll go into breakout rooms to be able to share and give feedback. We usually do about, I would say the piece that Hannah Kuhn wrote that I shared was probably written in about 15 minutes in a workshop, and then we all get a chance to reflect back and share our work if we want to, and give strengths-based feedback. So we don't want to have something that's overwhelmingly large. I tend to like if I can see everyone's faces on the screen at the same time, but we can go into breakout groups. It is labor intensive, but the impact we see is so transformational that we just want to keep doing it. So we're working slowly. We don't want to break it, you know, but and we're also training more and more people to become leaders and to join us in this work. So I hope that answered the question.
Yeah, absolutely. I mean, you started off by talking about, you know, the four types. Everyone will be a caregiver, and I think that's probably true. And so the demand is high, but yeah.
Thank you.
Thank you so much for your presentations. I really appreciate the work that you do, and I respect art as a medium to convey people's stories. I wanted to ask, is there any plan for you to be expanding to different art forms, like from paintings and such, for people to like convey their story, or?
So it's Amherst Writers and Artists. We primarily focus right now on writing and storytelling, but we incorporate other forms of art in some of the workshops. Some workshops that are done in the AWA method certainly include other forms of artistic expression. But I'll say that one of the things that's really important for these workshops is that we choose prompts that are particularly focused on caregivers, and we used a mixed media. We use paintings, we use music, we use poetry, we use writing, art. So we bring the art in on that end, but we may expand out in that way. I think one of the issues is having everybody have all the things that they would need to be able to create the art, but we're working on that, and it's a great suggestion, and I do think that leveraging the healing power of the arts is part of what we're trying to do here. So thank you so much.
Can I say one thing to it? which is so sorry. But there's a difference between what we do in this caregiving group as a sort of what we're researching together. We're doing this together, and also we each do independent workshops. So my workshops involve other forms of art as an intervention as well. It's just not in our study yet. So yes, come.
Thank you so much.
Thank you. Okay, our final talk of this session and of the conference will be by Sophia Weiss-Gotiandia, if I said that correctly. She's an early career researcher with a multidisciplinary academic background in biomedical sciences, social sciences, and philosophy. Her research interests combine philosophical and empirical methods, focusing on questions in epistemology, ethics, the philosophy of medicine, the philosophy of language, law, and their intersections. Sophia is additionally interested in the translation of research findings into actionable insights for clinical practice and health policy. She is currently a research associate at UCSF, working with Dr. Liz Zhang, colleague of mine, on the ethics of withholding and withdrawing life-sustaining treatments in the ICU and on addressing structural racism in serious illness care. The title of the talk will be Clinician-Reported Approaches to Withholding and Withdrawing Life-Prolonging Interventions Near the End of Life on the Ethics of Decision-Making Approaches Without Explicit Agreement. So welcome and thank you.
My name is horrible. I feel so sorry for anyone that has to try and pronounce it, having a Swiss German. So you said it very well. Having a Swiss German father and a Basque mother is complicated in more ways than one. So my talk is, and I must say I feel like almost perfectly teed up for this talk by Dr. Solomon, so thank you for that. It's entitled Clinician-Reported Approaches to Withholding and Withdrawing Life-Prolonging Interventions Near the End of Life. But I'm going to focus mostly in this talk on the ethics of decision-making approaches without explicit agreement. So just to say that I have no financial disclosures or other disclosures to declare. And so this talk is set up in the background of a systemic default in US medicine toward the provision of high-intensity life-prolonging interventions, which we've heard about today. And when I'm talking about life-prolonging interventions, I'm thinking about things like escalation to ICU level care and then the provision of life-sustaining treatment, so things like mechanical ventilation, vasopressors, amongst other things. And what's critical about this is that life-prolonging interventions are often initiated, continued, and escalated as a default, even when clinicians are concerned that they may be non-beneficial and may cause patients harm. Existing research suggests that clinicians have to proactively initiate decision-making to move away from this systemic default of the provision of these treatments. But actually in the literature, the specific decision-making approaches that clinicians use have not been particularly well described. And so we were interested in conducting an empirical study to look at, so which approaches do clinicians report using to do this? And critically, how do these approaches align with available guidance, if at all? And so I'm actually going to start with the available guidance, and I'm not going to canvass all of it. It's a limited talk, but I'm going to go over a few key multi-professional policy statements and some of the legal background. So Khan et al. Is a multi-professional policy statement on decision-making in the ICU from 2016 that basically recommends shared decision-making as the default model that ought to be used, including for withholding and withdrawing life-prolonging interventions in the ICU. And as we've heard, there is a reasonable amount, like a reasonable lack of conceptual clarity sometimes about what shared decision-making actually entails. They explicitly say that they don't settle this question in their policy statement, but they suggest that some kind of defining characteristics of shared decision-making are collaborative information exchange between patient or surrogate and clinician, deliberation, and then coming to a decision. Another policy statement that's kind of key in setting up this study is from Boslet et al. 2015, and they pick up on slightly trickier cases, so cases involving treatments that are potentially futile or potentially inappropriate. And we are moving away from the use of the word futile, but in this policy statement, they define futile interventions as ones that simply cannot accomplish their intended physiological goal, and these need not be provided by physicians. So clinicians do not necessarily need to engage in shared decision-making in order to be able to not provide or limit these treatments. I just want to add that the examples that are given of futile interventions in this policy statement are resuscitating a corpse and providing antifungals for myocardial infarction. So like that bar is extremely high. What does that mean? It means that we have this whole range of potentially inappropriate treatments where there is some chance of accomplishing one or other of a patient's desired effects, but clinicians believe ethical considerations may justify not providing them. And Boslet et al. Also suggests that if there's intractable conflict, that ought to be managed by a fair process of conflict resolution. And what's key there is that that should involve institutional oversight. There should be some sort of institutional mechanism or procedure to resolve that. The legal guidance, and I'm very indebted to Professor Pope on this because his work has been amazing in laying out the law of the land for me. But these were the states where our study took place. And just to say that in not very many states, California is an exception, but in about 2 states, there's green lights that are supposed to support clinicians or provide some safe harbor for withholding and withdrawing life-prolonging interventions, sometimes without achieving a shared decision. And we can see here that in California, it's when healthcare is medically ineffective. In some other cases, it can also be not when healthcare is medically ineffective, but when it is outside the standards of care. This is actually quite difficult to operationalize. A lot turns on how we define medical ineffectiveness, and obviously standards of care can vary, so it may be defensible that something actually, there may be different views about what falls within the standards of care, essentially. Okay, so to get to our study, what did we do? We did an empirical bioethics study employing a qualitative design in which we sought to learn which approaches clinicians report using in practice and to look a bit at how they may align with guidance. We interviewed 104 inpatient clinicians at 3 academic medical centers in California and Washington from across the hospital, and then we conducted inductive and deductive reflexive thematic analysis as per Brown and Clark, which is a well-established and rigorous qualitative analytic method if applied properly. And just to briefly talk through our participants, so we did 104 interviews in total. 87 of those interviews yielded excerpts relevant to decision-making toward the end of life for withholding or withdrawing life-prolonging interventions. There were 63 physicians in that sample, and they were from across the hospital, so emergency medicine, ethics, GERIs, critical care, internal medicine, palliative care. We also interviewed 16 ICU nurses, 6 advanced practice providers, 1 chaplain, and 1 social worker. And we generated this entire descriptive model for the approaches that clinicians report using to limit life-prolonging interventions. I'm going to focus on the bit in the middle, but just to set up the rest of the model for you. So we had these 3 approaches that you can see on the left, which broadly align with the 3 components that I've mentioned from Con et al. For shared decision-making. We then had this other approach on the very other side, which aligned with sort of invoking and utilizing an institutional mechanism for conflict resolution, as outlined by Boslet et al. And then we had these decision-making approaches that were quite interesting to us because they somehow seem to deviate away from some of the central tenets of shared decision-making. So they lacked some of those central features of sharing information about relevant treatment options and also allowing the patient sometimes to articulate a choice about those options. And they're interesting to us because they don't seem to be straightforwardly captured by policy statements or the law. To make this material for everyone, I'm going to give examples of what these approaches were. So the first approach we characterized as stating a plan to limit interventions. And here the speaking clinician presented a plan to limit interventions rather than options and proceeded with implementing that plan unless the patient or surrogate objected. So the quotation here is, I might say, it seems like if his heart were to stop, we have the whole hospital come running and try chest compressions. I don't think that would be reasonable. There's something I would put in the chart. It's called DNR. It's a stronger thing. It's not just, this is what I would suggest. Even a recommendation is sometimes too hard for families because it's their decision again. If I assent them to putting it in the chart, I can say that I talked to them about it and they were okay with it. The next approach was a little bit stronger, so it was explicitly not offering interventions where the clinician conveyed a final decision to limit interventions and they sought not to allow for objections. And here we have another example quotation. I feel comfortable saying we're not going to do CPR because it's just going to prolong death. You don't have to offer things to people that are not going to be helpful. You're not obligated to Zosyn someone if you don't think they have pneumonia just because they want Zosyn. CPR is the same thing. And then the strongest approach was actually not mentioning interventions at all, where the speaking clinician just entirely omitted mention of an intervention from the conversation, so not providing either information or choice. And the example here is, sometimes I give a little less information if I think they're going to grab onto something that has a 0.0005% chance of happening. Sometimes I don't offer ICU level care. I say, your mom is dying and I'm going to give her medicine so she's not struggling to breathe, and make whatever moments or days she has here the best they can be. Brief interlude on, so what does the bioethics literature say about all this? There's actually not too much in the literature. It talks generally around the practice. It doesn't delineate the specific approaches that I've mentioned in this talk, but to canvas kind of 3 seminal papers, Whitney and McCullough sort of recognize sometimes physicians make silent decisions, so without disclosing or involving the patient in shared decision-making. Magnus and Risk draw a comparison between intensivists and surgeons and some interventionists, and the surgeons might disagree with me, but they take the view that historically, surgery has sometimes been able not to offer or to limit without shared decision-making. And they suggest that actually they don't see an evident asymmetry between the surgeons, interventionists, and the intensivists, and perhaps they ought to be able to not offer or sometimes to limit interventions without shared decisions. Wickler and White take the opposite line, and they argue that actually no, surgery ought not to be able to do this, and they ought to be subjected to more procedural oversight for these decisions. So just to say it's complicated, I hope to have put across that this is contested terrain in the literature, and it was also contested terrain in our interviews. Participants expressed a lot of uncertainty about these approaches, which centered on sort of 3 areas. One was their ethical permissibility, 2, their feasibility, and also their degree of comfort using them. And just to say that there was such a variety of perspectives when we were analyzing these data that we called it the Wild West, which is, we have this picture on the screen. So the first question centered around, is limiting without explicit agreement or without some of these features of shared decision-making ever ethical? And this sort of had 2 axes to it. The first axis was, what might be appropriate grounds for justifying that ethical permissibility? So is it that a particular intervention is medically ineffective or harmful or hurtful, unlikely to change the outcome? Like, how do we ground that ethical judgment? And the second piece of whether it was ethical turned on essentially whether there were some interventions that cannot be offered in this way and whether there are others that might not be able to. So the example that brings this out is it possible not to offer CPR in the same way that it might be possible not to offer surgery? So the quotation here is, what is this family going to hear about from their friends, from their family? If their patient dies without that discussion explicitly being had, are they going to regret that? Are they going to feel there was any dishonesty or lack of complete sharing of information? So trying to figure out when it's better to be more transparent. The next set of concerns was around whether these approaches were actually feasible. Like, could the clinician get away with doing this in a sense? And this example brings this out perfectly. Dialysis is a perfect example where I say, I don't think dialysis is a good idea. I don't think it's going to reach these goals. Can we talk to the kidney doctor? Of course, right? You can't just say, I'm the dictator. You have to allow people to talk to someone else. And so the kidney doctor shows up and says, of course we can do dialysis. And then just to say that clinicians were very variable in their level of comfort with using these approaches. And the quotation here is, If there's a very strong case for why something shouldn't happen, some clinicians use their medical knowledge and interpretation of what's happening and make those decisions, and they don't ask anybody. But those are very specific individuals who I know feel comfortable doing that. So why are these approaches of interest? Well, on our reading, these approaches seem to try and alter the choice architecture to either make these difficult decisions easier, to avoid them entirely, and to try and circumvent possible conflict about whether to limit life-prolonging interventions. I want to restate that respondents really talked about these approaches in the context of what they felt they were doing, being trying to prevent patient harm. And so where they had like a reasonably high confidence, even if they didn't meet the bar for futility, that the treatments that they were going to be administering might be potentially non-beneficial. But as I've sort of tried to bring out, these approaches don't strictly, squarely seem to align with multi-professional policy statements or conform to the legal guidance, or at least it's unclear how well they do. And that leaves us with a question, essentially, ethically, what should we make of such decision-making approaches without explicit agreement? And I want to suggest that there are multiple options, but I'm going to focus on two to round out. One view could be to say, well, we actually ought to hold the bar high, and we shouldn't lean on these kinds of approaches. We should try and recenter shared decision-making and somehow train and empower clinicians to be able to use those approaches across contexts and not have to lean into these other ones. And another view might be to say that a kind of the sort of sociological systemic default toward the provision of these treatments is an extremely non-ideal context, and we might want to be a bit more charitable towards clinicians potentially and think about when and how leaning into these kinds of approaches may be ethically permissible. I don't want to take a normative stance on that question in this talk, but just to suggest that we might want to think further about when we want to delineate the kinds of cases that might be good and that might be bad. So in conclusion, we think this is interesting. Part of why we think this is interesting is because it's one of the few empirical studies, to our knowledge, where clinicians attest to limiting life-prolonging interventions without explicit agreement explicitly. Our interpretation of this is as non-ideal decision-making in the context of a systemic default toward life-prolonging interventions, which Dr. Solomon spoke about today. And it raises questions, and because we're at the end of the conference, I'm going to leave those questions there, but talk about the questions I actually think are most interesting, which is partly how thin or thick do we want our concept of autonomy to be? How do we make progress in settling the debate of what respecting patient autonomy actually entails? And maybe also a broader sort of sociological and structural conversation that needs to be reopened about how we want to delineate the goals of medicine and the role of the physician in a changing society where medical technology is constantly increasing and becoming better in some ways and perhaps worse in others. Thank you.
That was great. Thank you. Actually, outstanding. I wonder if the framework might change based on the decision being made. So DNR, DNI came up.
Yeah.
Dialysis came up.
Yeah.
ICU care came up. Mm-hmm. These are three things that patients with no experience of the medical system, which is fairly still rare, but most people have some experience, but these are three things that have meaning for people because they've seen it on TV, they've heard about it. And the problem with the Zosyn example is no one actually cares about Zosyn. Mm-mm. But dialysis has meaning because, like, if we're withholding dialysis, that really shows something about what the institution believes or the physician's team care. So I'm wondering if it might matter about how we do this based on the decision being made, or whether there's certain exceptions for some decisions because of the meaning that they have for patients, even if it's clinically disconnected from what's right. They might be futile, they might be potentially inappropriate, but the decision means something to the patient.
Totally. I mean, I sort of feel like that's, well, I'm going to bring out two things here. I feel like that's sort of the central question. I mean, part of what we've talked about throughout this conference is that there may be things that are non-beneficial from the clinician's perspective, but that may have some other different kind of value for patients. And it's not entirely obvious to me where that might fall. And I think that's why I've personally tried to avoid being normative with it. In part because being a kind of qualitative study, what we were trying to bring out is like what, from clinicians' perspectives, what are their ethical judgments that are leading them to do this? And I don't want to say necessarily that those judgments are right or wrong. I also think that it will depend, and I think the other example that I wanted to bring out that I was discussing today is like, how does it change when things become standard of care? So at the moment, these kinds of things don't really happen with tech, or seem to happen less with technologies like ECMO, but the standard of care is changing so quickly that I think this probably isn't a static thing. It's quite dynamic.
Yeah.
Hi. Some of these strategies remind me strongly of the concept of informed non-dissent. And I'm curious how you situate that concept. I think Dr. Khan has written about it, and it's written about a lot in the pediatric literature. And also how Wynne Morrison wrote about titrating directiveness and situating that in shared decision-making. And I'm curious about how those concepts might fit into this model.
Totally. So I presented 3 sort of approaches that we delineated, and we actually debated whether to call the first one that I present informed dissent or not. And we chose to kind of come up with our own sort of description for it, just based, like really grounded in trying to be very descriptive about what people were saying in the sample. But I do totally agree with you that there is some overlap that can be brought out, especially in that approach. And I'm trying to remember the second part of the question. Sorry. It's been a long conference.
What, it's like at the end or something. I don't know if you're familiar with Wynne Morrison's work, but she talks about shared decision-making and how clinicians can titrate their directiveness in the spectrum of, giving people a laundry list and letting them choose to being more directive, and that can be negotiated with your, she's a pediatrician, so it's how that you can negotiate that with your patient's parents and direct the level of titration, or titrate the level of directiveness you take, which also reminded me of elements of some of your quotes.
Totally, and also I showed kind of like simplified model of the version of the descriptive model, but we also had a kind of extra axis that we added on it based on the kind of strength of the clinician, the strength with which the clinician was trying to direct the patient or the surrogate. So that's definitely also a piece of the equation. And then the final thing I'll say is, and I didn't really touch on this in the presentation, but it has been mentioned at the conference, the kind of second order desire thing. So there's also, we also recognize that patients and surrogates have preferences about not just like the decisions that they want to be made, but how they want decisions to be made. And sometimes that can involve, handing off more or less responsibility for decision making to clinicians. So that's also a piece of it.
So I'm going to ask one last very quick question then, because that was, I was very interested in whether or not surrogates or family members ended up in any of these descriptions, as in, we think we're doing the right thing, this doesn't benefit the patient, but the family or surrogate's requesting it, and we're going to do it for them.
Yeah, so the idea that sometimes you're treating the family or the surrogates rather than the patients came up. I didn't bring them up into my examples, but that definitely came across in our interview data.
Fascinating, great.
Thank you.
Okay, well, I want to thank you for your talk and all the speakers in this session. Thank you very much.
So it's we're 2 minutes early. It's just unbelievable. Yes. So yeah. Congratulations. Yeah, Micah. Well done. So I am taking the prerogative because I made the schedule to have the last word, and so I want to give some thank yous. I really want to thank the presenters throughout the conference in the various different modalities in the breakout groups, the plenary sessions, the concurrent sessions, the posters. I think people really did a fantastic job. I want to thank all the moderators who are all faculty of the MacLean Center, with a few exceptions of some special favors that people did for me. And so I appreciate all of you. And in particular, I do want to thank the audience. So for all of you, and especially those of you who stayed till the end of the conference on Saturday afternoon, I really appreciate it. I want to also thank the MacLean Center staff who did a great job. I want to thank Meeting Achievements, which this is the first year that we did hire an event coordinator, and it was, I think, well worth the investment. I want to thank our AV team, Vantage AV. You guys did a great job. And I also want to thank the MSI staff who did very nice work throughout the last 2 days. I want to encourage you, those of you who presented, to consider submitting your manuscripts to the Journal of Clinical Ethics. There is no guaranteed acceptance, but there is a guaranteed close reading of your manuscripts. And that, I think, is what the responsibility for any great journal is. Please look for the call for abstracts for next year and consider submitting and encouraging your colleagues who do good work to also submit. Please consider nominating luminaries in the field of clinical ethics for the MacLean Prize. And plan to return next year and encourage others to do so. It's really, from my perspective, it's been an outstanding conference, and the presentations are part of it, but just the discussion and the collegiality is also a major part of it. So with that, we stand adjourned. Thank you very much.